Let's dive right into this explainer. If you've been staring at a mountain of nursing study guides, desperately trying to connect the dots between pharmacology, human development, and infection control, you are in the exact right place. Today, we're going to take all those dense, heavy concepts and turn them into a high-yield crash course. And the way we're going to do that is by viewing the human body as a dynamic, living fortress. We're going to look at exactly how it's built, how it defends itself, and the heavy-duty weapons we bring in when those defenses are finally breached.
So here is our battle plan for today. We'll start off with growth and development, then move right into inflammation and infection. After that, we'll cover transmission and precautions, jump into how medications work, unpack our drug arsenal, and finally look at vaccines and immunity. Let's get to it. Section 1, Growth and Development. Building the fortress.
Okay, so this is where we lay the foundation. You see, we really can't treat a patient effectively if we don't understand the cognitive and psychosocial blueprints of how they develop in the first place. It is absolutely vital to contrast two of our foundational theorists here. On one side, we have Jean Piaget, who brilliantly maps out our cognitive leaps. For example, an infant in the sensory motor stage. They're exploring the world entirely through their five senses. But on the other side, we have Erickson, who looks at psychosocial milestones. Take a toddler in the pre-operational stage. Erickson points out their main psychological battle is autonomy versus shame and doubt. They're constantly testing our limits, right? Trying to assert that independence. Understanding both of these perspectives gives you the complete 360-degree picture of your patient's development.
Now, right between 12 to 18 months, our little fortress commanders achieve a massive developmental leap: object permanence. They finally figure out that an object still exists even when it's totally out of sight. And at the exact same time, they're hitting the huge physical milestone of walking independently. Let me tell you, this is an absolute must-know timeframe for both your exams and clinical practice. Section 2, Inflammation and Infection. The fortress under siege. So what happens when our fortress takes a hit? The most crucial thing to wrap your head around here is that inflammation and infection are not the same thing, even though they love to show up to the party together. Inflammation is basically your body's vascular 911 response. It rushes blood and white blood cells right to the site of an injury. You're going to see the classic 5 cardinal signs: redness, swelling, pain, heat, and loss of function. And this can happen without any infection at all, like when you twist your ankle. An infection, on the other hand, is an actual pathogenic invasion. We're talking bacteria, viruses, or fungi literally breaching the walls. That brings on the fever, the chills, the pus, and a noticeably elevated white blood cell count. When an infection actually does strike, it follows a very predictable 6-step battle plan called the chain of infection. It starts with an infectious agent chilling in a reservoir. It finds a portal of exit, grabs a mode of transmission to travel, finds a new portal of entry, and successfully invades a susceptible host. As nurses, our primary mission here is incredibly simple but absolutely vital. We just have to break one single link in this chain to stop the invasion in its tracks. Section 3, Transmission and Precautions. Defending the walls.
So how exactly do we break that chain? We deploy our specialized defensive shields, also known as transmission-based precautions. This right here is an incredible clinical cheat sheet. Airborne invaders, they need a negative pressure room and an N95 mask. Just remember MTV, that's measles, TB, varicella. Droplet invaders, which are a bit heavier and don't travel as far, require a surgical mask. A great memory trick for that is Spider-Man, which covers bugs like mumps and rubella. And finally, contact precautions require a gown and gloves to physically block transmission from surfaces.
Let's look a little closer at contact precautions, because this translates directly into real-world practice, specifically with C. diff. Listen, if you remember only one single thing from this section, make it this. C. diff spores are basically tiny armored tanks. Alcohol hand sanitizer, it does absolutely nothing to them. You must wash your hands vigorously with good old-fashioned soap and water to physically wash them down the drain. Plus, you absolutely cannot share equipment between rooms, and you have to wear your gown and gloves every single time. No exceptions.
Okay, so we've put up the walls, we've washed our hands, we've got our masks on. But what happens when those external and natural defenses fail and the pathogens actually get inside the fortress?
Section 4, How Medications Work. Reinforcements arrive.
When it's time to call in the heavy reinforcements, those pharmacological weapons have to actually navigate the body's internal systems first. We call this journey pharmacokinetics, which literally just means what the body does to the drug. It's a clean 4-step process. First, absorption. The drug moves from wherever you administered it right into the bloodstream.
Second, distribution. It travels through the blood to the actual site of action. Third, metabolism. The drug gets inactivated and broken down, and this happens primarily in the liver. Finally, excretion. The leftover remains are eliminated from the body, mostly by the kidneys. Why does this matter? Well, if a patient's liver or kidneys are failing, these medications can accumulate fast and become highly toxic. To make sure we don't accidentally poison our patients, we rely on the therapeutic index, which is just the measurement of a drug's effectiveness versus its harmfulness. For drugs with a really narrow index, meaning the difference between a healing dose and a lethal dose is dangerously small, we have to draw blood to monitor the peak and trough levels. The peak is the drug at its absolute maximum effect, and the trough is the lowest level in the blood just before you give the next dose. Section 5, the drug arsenal, weapons of choice. Now that we know how these medications travel, let's crack open the armory and look at the actual weapons, starting with anti-inflammatories. There is a huge difference between first and second generation NSAIDs. First generation meds, like aspirin and ibuprofen, are totally non-selective. They block COX-1, which normally protects your stomach lining, and they block COX-2, which triggers the inflammation. Because they block COX-1, they come with a really high risk of stomach bleeding and irritation. Second-generation NSAIDs, like Celebrex, are the literal snipers of our arsenal. They selectively block only COX-2, so they fight the pain and inflammation, but leave the patient's stomach lining completely alone. Moving on to antibiotics. These are your high-yield must-knows for exams. Penicillins, they are the most common cause of drug allergies, hands down. Aminoglycosides are massive heavy hitters, but they're ototoxic and nephrotoxic, meaning they can seriously damage the ears and kidneys. Tetracyclines will cause permanent tooth discoloration, so that's a hard no for pregnant women or kids under 8. Fluoroquinolones carry this totally bizarre but very serious risk of tendon rupture. And Flagyl, it's great for treating anaerobic infections and C. diff, but if the patient has even a single drop of alcohol within 48 hours, they will get violently ill. But what about viral invaders like HIV? Well, HIV systematically targets and destroys the fortress's command centers, the CD4 helper T cells. When a patient's CD4 count drops below 200, that indicates clinical AIDS, which leaves them totally vulnerable to opportunistic infections that could be deadly. To fight back, we deploy HART, highly active antiretroviral therapy. The entire goal here is to keep those CD4 cells up and brutally suppress the viral replication until it's completely undetectable. Switching gears just a bit to upper respiratory infections. When we use first-generation antihistamines, like Benadryl, to dry up a patient's secretions, they come with what we call anticholinergic side effects. If you want a memory trick that will stick with you forever, just remember this slightly ridiculous but perfect phrase: can't see, can't pee, can't spit, can't boop. It perfectly describes that extreme drying and retaining effect these meds have all over the body. Section 6, vaccines and immunity. Upgrading the defenses. So how do we proactively upgrade the fortress so that the invasion never even happens in the first place? We do it by stimulating active immunity. This is when your body actually makes its own antibodies. It can happen naturally, like by getting sick and recovering, or artificially, through a vaccine. A vaccine safely exposes your body to a weakened antigen, which fires up your B lymphocytes to create a permanent memory file. That way, if the real deal pathogen ever shows up, your fortress already knows exactly how to destroy it. The CDC's scheduling guidelines actually show us how we roll out those upgrades across a human's entire lifespan. Right at birth, we kick things off with hepatitis B. At that critical 12 to 15-month mark, remember, right when they're walking and figuring out object permanence, we give MMR and varicella. Fast forward to adolescence, around 11 to 12 years old, we introduce Tdap, HPV, and meningococcal vaccines. And finally, for our older adults, age 65 and up, we focus on protecting the lungs with the pneumococcal vaccine. Of course, building up all these new defenses takes energy, and that brings us to side effects. It is absolutely crucial for you to educate your patients on what is normal. A mild fever, fatigue, irritability, and soreness at the injection site? Totally expected. That's just the immune system actively working to build those memory antibodies. What is not expected are serious reactions like anaphylaxis, throat swelling, or severe hives. Knowing the difference between the two allows you to reassure worried parents while staying hypervigilant for a true medical emergency. We have covered an immense amount of ground today. We've built the fortress through developmental milestones, recognized the signs of it being under siege by infection, deployed our transmission shields, and reinforced the walls using complex pharmacokinetics and targeted vaccines. But I want to leave you with one final thought. Masterfully memorizing all these facts is great, but how will you apply these critical connections when you are the one standing on the front lines of patient care? Because at the end of the day, seeing exactly how these biological, developmental, and pharmacological systems interact is what transforms you from a student reading a textbook into a nurse capable of saving a life. Keep connecting those dots and keep learning.